So today we will discuss all the important concepts of psoriasis that are asked in USMLE. Psoriasis, as we can see, these are two images of psoriasis, and psoriasis is a scaly and erythematous plaque. These three words are important. As we can see in this image, it's scaly, it's reddish, and it is a plaque. These describe psoriasis, and if we try to scrape off these scales, then it leads to pinpoint bleeding, and this is known as, after a scientist, Auspitz sign. Auspitz sign. Now, the common locations of psoriasis is, always remember, psoriasis on the extensor surfaces of extremities like the elbows, the knees, and it can also occur on the scalp area, the genital area, and the sacrum. So these are the important locations of psoriasis. The triggers for psoriasis are, if we get a trauma like we fall down or anything, this is known as Koebner's phenomenon. And some medications, it can be both due to addition of a medication or due to withdrawal of a medication. Withdrawal from glucocorticoids or addition of certain meds, like, it is not important, but like antimalarials, indomethacin and propranolol. And also some infections predisposed to psoriasis like HIV and strep pharyngitis. This is a very high yield for USMLE if a patient has aggressive onset psoriasis. Always think about HIV, and especially if there is a history of any sexually transmitted disease like herpes. The next best step is offer screening for HIV. Always remember, offer screening for HIV and rapid onset psoriasis. The pathogenesis of psoriasis is quite simple. All these triggers are due to autoimmune mechanism. The epidermis leads to thickening, the keratinocyte proliferation in the epidermis leads to thickening and scaly appearance of the epidermis, and also in the dermis there is angiogenesis, which leads to widened, twisted and new blood vessel formation. So let's move on to the extradermal manifestation of psoriasis. First is joint problem, that is arthritis, nail changes, that is pitting, onycholysis or oil spots and salmon spots, and third is eye. In eye we can get uveitis, conjunctivitis. So these are very high yield for USMLE because they show images of nails and ask what is the problem that the patient has. So always pitted nails, onycholysis, and psoriasis, and in these we can see this oil droplets. These are known as oil droplets or salmon spots. The treatment of psoriasis is according to the involvement. If there is limited involvement, obviously we will give topical. If extensive, then photo, and if very extensive, then systemic therapy. For topical therapy, we give immunosuppressant like hypertensive glucocorticoids, betamethasone and fluocinolone, calcineurin inhibitors like tacrolimus, and also we give vitamins like vitamin D analog calcipotriene, vitamin A analog retinoids, and tazarotene. With tazar, you can always remember tar, but tar is not a vitamin A analog, but it was given for therapy of psoriasis as a topical agent. Now for phototherapy, we can give PUVA or UVB, and for systemic, the same way, immunosuppressants like calcineurin inhibitors, tacrolimus, biological agents like methotrexate or TNF alpha inhibitors, or vitamin retinoid. And as the last resort, or last, you can remember like last, epidemiolast. It is mainly used for psoriatic arthritis. It is a PDE analog. We don't need to get to the details, specific details, but it is given in UWORLD, so you should remember. And the toxicity obviously increases from topical to phototherapy to systemic. Thank you for viewing this video, and like and subscribe for more such videos. Have a good day.